Great. Thanks so much, everyone, for coming to the course and for hanging around for Saturday afternoon talk. We have a pretty small group, which is great. So this can be very interactive if you like. I have the chat open and I only have one screen, so I can't follow the chat and the Q&A. So if you wouldn't mind, please put any questions or comments or things you want to discuss in the chat. We're going to go over some cases and we'll also have a time after each case to have discussion. We probably won't go the full 90 minutes, so you'll get to dinner early, hopefully. Oops. I don't have anything to disclose. I will discuss some off-label use when it comes to pediatric diabetes, I think, and MASLD in particular, but I'll say when I'm discussing off-label use. And I don't have anything else to disclose. So I want to use a case-based discussion to review a few different topics, the usual patterns of puberty and growth and their normal variations, pediatric type 2 diabetes, obesity, and MASLD, GH deficiency, how we diagnose it in pediatrics and how we manage it during the transition, endocrine surveillance for childhood cancer survivors, and current practices in transgender care for those less than 18. So we'll start with the first case. The purpose of this case is mainly to kind of review the timing of puberty. This is a 13-and-a-half-year-old who came to our clinic because his parents were concerned about his stature. They said that he'd always been small for his age, and his growth they felt like had slowed recently. And indeed, when we took his past measurement and his measurement in our clinic, it looked like he'd only grown about 1.5 inches or 3.8 centimeters in the past year and a half. He was feeling well and didn't have any health concerns, and his history of present illness was unremarkable. His medication history was unremarkable, and there was really nothing notable either in his past medical history, birth history, or social history. His mom was 165 centimeters and his dad was 180 centimeters. His mom had had menarche at age 15, and his dad noted that he had finished growing in the first year of college, and there hadn't been any other family history of short stature or delayed puberty. But as we go through the timing of puberty, you'll note that menarche at age 15 is a little bit late, and growing until age 18 or 19 is also just a little bit late. So family history of delayed puberty. On physical exam, his measurements are shown here. He was only second percentile for height, and you can see that he had been a higher percentile before, about a year and a half ago. His BMI was normal, and his exam was otherwise unremarkable. We do visual fields to make sure we're not missing a large pituitary situation. And obviously, we do a pubertal exam, and on the pubertal exam, he was Tanner 2 with testes 4 cc's bilaterally, which is kind of right at the very beginning of puberty. He did have axillary hair. And as I mentioned before, his growth velocity was low. We typically want to see people grow at least 4 to 5 centimeters a year before puberty, between the ages of about 4 and puberty, and his was low. So I wanted to take a step back and do a quick review of pubertal timing, which is something that as adult endocrinologists, you probably don't think about as often as somebody like me does. So the average age for Tanner stage 2 in boys is about 11 and a half, but it can range anywhere from 9 to 14. And really the hallmark of Tanner 2 for us is the testes becoming 4 cc's in volume or greater. And we also will notice a change in the texture of scrotal skin. Then in Tanner 3, which happens around age 13, we'll see continued increase in testicular size, and that's when you start to see a more marked increase in penile length. In Tanner 4, you have continued increase in testicular size, and that's when you'll see more of an increase in penile width as well as length. And then Tanner 5 is adult male genitalia. The growth spurt for boys is typically between Tanner 4 and Tanner 5. And the expected duration once a boy starts puberty to when he'll be Tanner 5 is about 2 to 4 years. And in Tanner 5, after the growth spurt, growth starts to taper, similarly to how it does in girls, which we'll review in a minute. And so with average pubertal timing, growth starts to taper by about 16, and growth will typically be complete by around age 18. This is a review for females. Everything happens about a year earlier. And in addition, you'll notice that the growth spurt, instead of being Tanner 4 to 5, as it is in boys, is actually Tanner 3 to 4 in girls. And this is one of the reasons that a lot of boys get concerned about their growth, because they see girls all around them going into puberty a little bit earlier and having growth spurts a little bit earlier. So the average age for Tanner 2 in girls is 11, and the range is 8 to 13. And the hallmark is breast budding. So breast tissue right under the areola. You also can see some areolar enlargement. In Tanner 3, you see continued growth of the breast tissue beyond the areola. In Tanner 4, you see a separation in contour. So there's like a breast contour, and then there's a separate areolar contour, or what's called a secondary mound. And then this recedes in Tanner stage 5, such that there's, again, a single contour. Growth spurt, as I said, is between Tanner stage 3 and 4, and menarche typically happens at Tanner 4 or Tanner 5. Similar to boys, once you kind of start breast budding, the expected duration of puberty is about 2 to 4 years. And on average, girls grow about 2 inches over about 2 years after menarche. So for example, if a girl has menarche at age 13, you're going to expect her to grow a couple of extra inches after that and probably stop growing around age 15 or 16. So if a girl has not had any pubertal development by age 13, then we consider that to be delayed puberty. A boy who hasn't had any development by age 14 is considered delayed puberty. And if a girl doesn't have menarche by age either 15 or 16, you'll see different definitions in different places, then we consider that to be primary amenorrhea. I also wanted to review patterns of growth. I mentioned that we expect people to grow at least 4 to 5 centimeters a year between age 4 to 5 until puberty. This is a growth velocity chart, which you probably don't look at much if you're an adult endocrinologist, but we look at a lot as pediatric endocrinologists. The important thing here, first of all, let's just look at the blue lines, and the blue lines is sort of for somebody who has average pubertal timing on this side of the graph, and this is for boys here. There's a similar chart for girls available, of course. And so you notice that growth velocity kind of is very high between ages 3 to 4, tapers off a little bit, is lowest right before puberty. We call this sometimes the prepubertal slowdown, but it's very uncommon. It's kind of less than third percentile for it to get below 4 centimeters a year here, as you can see. And then there's the growth spurt, and then the growth tails off. And what you see here in green is an early maturer. So you see that they have their growth spurt earlier and tail off earlier, of course, and a late maturer has their growth spurt later and tails off later. And generally speaking, the timing of puberty doesn't really predict. We don't think the final adult height. That's predicted by genetics, unless somebody has significantly early puberty, and then of course they may pathologically early puberty, and then they may finish growing earlier and be shorter than expected. But this graph shows the height in somebody with average pubertal timing, somebody with constitutional delay, and somebody with constitutional advancement. And basically, if you're going to have constitutional advancement, typically you grow faster before puberty, you grow faster during puberty, and then you stop earlier. Whereas those with constitutional delay grow slower before puberty, have a slightly attenuated growth spurt, but grow for longer. The next thing we did for this patient is get a bone age, and in most cases of growth, we do end up getting a bone age. And the patient's bone age is shown here, and these are the reference bone ages for 11.5 and for 13.5. And so you can see his chronological age was 13.5. Different people look at bone ages different ways, but most of us look at kind of the phalangeal epiphyses the most. And if you were to sort of compare these and these, you'll see that they look more similar to these. Here, these are sort of kind of beaking up toward the metaphyses, whereas here they are not. So this patient's bone age was read as 11.5. You probably have seen there are predictions. So if your bone age is 11.5 and you have a height of X, we can tell how tall we expect you to be as an adult. So this patient had a predicted adult height of about 170 centimeters or 67 inches. We also did labs, and the reason I did labs, I don't always in these cases, but because the growth velocity was less than 4 centimeters a year, I did do labs. His KIM7 was normal, his thyroid studies were normal, his IGF-1 and IGF-BP3 are shown here. And similar to what you guys do in adults, looking typically for a Z-score, our lab reports will come hopefully with Z-scores for IGF-1, or at least tables that give them according to sex and pubertal stage. And IGF-BP3 norms also vary by age or pubertal stage as well. He had a negative celiac screen, his CBC was normal, his ESR was normal, and he had early pubertal labs, as you can see here. So if you wouldn't mind, just type a diagnosis in the chat of what you think this patient has. Okay, or if you're listening on a walk, I will go ahead. Hey, thank you. Small familial short stature. Fantastic. Great. Thank you very much. So this is constitutional delay of growth and puberty in a patient who had whose mom had menarche at 15 and dad continued growing sort of into the beginning of college. What we did is we treated this patient with intramuscular testosterone, 50 milligrams once a month. Yes, thank you. Yes, constitutional delay of growth and puberty. Perfect. This treatment with testosterone is what we kind of call psychosocial. This is not medically necessary by any means, but a lot of boys have great distress around this when they're feeling smaller and they're feeling less developed in the locker room, et cetera. There's some possibility that giving testosterone, quote, jumpstarts puberty the same way that, say, kids with CAH who have exposure to peripheral testosterone then are more likely to have early central puberty. But it's most of us think it's probably most likely that we're temporizing and making kids feel better. So again, not a medically necessary treatment, but that's something that he wanted. He had continued pubertal development when he discontinued testosterone. We repeated a bone age a year later, still about 18 months delayed, and predicted height similar, and he was discharged from endocrine care. So you can see his growth spurt here, or his growth, sorry, and he was very early in puberty, so he went on to have a growth spurt, presumably. So again, constitutional delay, something we see very commonly. I mainly wanted to use the case to go over the patterns of pubertal development, and we do sometimes treat this with testosterone, but that's not something that's medically necessary. It's something that more likely is kind of a temporizing thing for kids with psychosocial distress. Any questions or comments, please put anything in the chat if you, or feel free to unmute yourself if you have any questions or comments. Okay, we will go ahead to case 2. This is a 10-year-old who presents for a well child check, and this was in June of 2018. The BMI at that time was 30.5, and he had a rash on his neck. Otherwise, his exam and his HPI were unremarkable, and the primary care doctor did send screening labs because of the obesity, and you'll notice he had some hypertriglyceridemia. He had transaminitis or elevated AST and ALT. His hemoglobin A1C was 6.8%. in the diabetes range, and his TSH was normal. So he was referred at that time, the 10-year Welsh child check, to pediatric endocrine for an elevated A1C. He was started on metformin, but the parents stopped after 4 weeks, reporting that they were kind of waiting for a follow-up appointment and weren't sure what to do. And he was referred to pediatric GI for NAFLD. As you guys know, the name has changed recently to MASLD, so forgive me when I regress. But metabolic dysregulation associated steatotic liver disease. He had actually been found to have that on ultrasound 2 years prior. He had a FibroScan at this time at age 10, consistent with mild fibrosis, and it was recommended that he restart his metformin and undergo lifestyle modification. So 16 months later, we're now at his 12-year well child visit. He has had a 15-kilo weight gain in the past year. His family hadn't followed up with either subspecialty and had discontinued metformin. And at this time, his A1C was 7, and he still has elevated AST and ALT, as you can see there, and he was restarted on metformin. About 8 months later, he went to the urgent care facility with abdominal pain, nausea, and vomiting, and reported polydipsia and polyuria, as well as some arm weakness. He had had trouble getting to the pharmacy and hadn't had any metformin for a month. And as you'll see here, he was in DKA. And this is actually an unfortunately common presentation of DKA and an uncommon a common presentation of type 2 in youth. So I'm actually not giving you an extreme case here, even though it seems like I might be. We actually see this an unfortunate amount. So I show you here his weight curve. I'm going to talk about this a little more, but one thing to point out if you haven't seen it yet is that we now use this extended BMI curve, and I'll talk about this in a slide a little bit later, but you can see that he kind of all through childhood was about 130% of the 95th percentile BMI. He was first noted to have an elevated ALT and AST around age 8. And this is his hemoglobin A1C graph along the bottom here. Whoops, sorry. Okay. And so you can see that his hemoglobin A1C shot up, of course, when he presented in DKA, and then went back down with treatment. So what I want to use this case to talk about is type 2 diabetes in kids, which is actually much different than it is in adults. I want to talk about MASLD in kids, the management of pediatric obesity, and transitions in diabetes. And thank you, Sheldon McKenzie. I will answer your question. Thanks very much. I might just break and answer it now. So what are the pearls that point to growth hormone deficiency versus constitutional delay of growth and puberty? So thanks, that's a fantastic question. Growth hormone deficiency is typically accompanied by a decreased growth velocity, and we did see that in this case. However, his IGF-1 was completely normal and his IGF-BP3 was completely normal. In growth hormone deficiency, we typically see a sustained reduction in growth velocity. We do see a delayed bone age, but we often will see a predicted adult height that's actually less than the mid-parental height, whereas in this case, the constitutional delay had resulted in a delay in bone age that yielded a predicted adult height that was congruent with the genetic potential or the mid-parental height. And we have a case of growth hormone deficiency coming up, I think, next. So we'll go over that a little bit more at that time. We also in constitutional delay do typically see a parental history of delayed puberty, and it's often, again, in these two parents, it wasn't outside the range of normal. The mom had menarche at 15, which is normal, but late, and the dad had kind of normal but late. But you do typically have a family history as well. Thanks for the question, and please keep putting questions in the chat. So back to this case, I want to start with a quick aside about measuring obesity, which I just mentioned. And this may be new to you. We now are measuring people by percent of the 95th percentile BMI. And the reason for this is because our CDC charts are based on data from 1963 to 1994, and there just weren't a lot of kids above the 95th percentile for BMI. Especially there weren't a lot of kids above the 97th percentile. So when a child has severe obesity, they're kind of all scrunched into that 95th to 99.9th percentile, and it's really hard to differentiate between degrees of severe obesity. Because of this, the new proposed solution is percent of 95th percentile BMI, which is a mouthful. It's clunky, but it does work pretty well. A percent of 95th, and the way you calculate it is you take the patient's BMI and you divide it by the 95th percentile BMI for that patient's sex and age, and then you get a percentile. So if you have a percent of 95th percentile BMI of 120%, that corresponds about to the empiric 99th percentile, and that's the recommended cutoff for severe obesity, which we'll go into at the next slide. And I want to just show this chart to give a sense of why we're using this. So if you have a 10-year-old girl, the 23 is the BMI at the 95th percentile. So if she has a BMI of 23, her BMI percentile is 95th. her Z-score is 1.66, and her percent of 95th percentile BMI is 100. If her BMI goes up by 6 to 29, her BMI percentile is 99th. This is her Z-score, and this is her percent of BMI, percent of 95th percentile BMI. If she goes up a whole additional 5 kilograms per meter squared, her percentile just goes from like 99th to greater than 99th. And her Z-score just goes up a little bit here. But it's better reflected in the fact that the percent of 95th percentile BMI goes up from 126 to 148, and so on. So you can see sort of a better discrimination using the percent of 95th percentile BMI as compared to the Z-score and the percentile itself, which really compress all these kind of very large gains in BMI once you get above that threshold. So we have 2 different definitions of obesity in kids. The first is just severe obesity, and this is for kids who are above the 120th percent of 95th percentile BMI or have a BMI above 35, like an absolute BMI of above 35. And then another way, and what most people use, I think, is these kind of classes. So class 1 obesity is if you're greater than 95th percentile, but you're less than 120% of the 95th percentile. Class 2 is from 120 to 140% of the 95th percentile. And class 3 is above 140% of the 95th percentile. And again, if you use medical record software, typically they'll have these extended BMI charts that have these percent of the 95th percentile. This is new over the past kind of 5 to 10 years. It was been used in research for about the past 10 years and used clinically for about at least the past 5 years. And I think everybody's familiar with this by now, but we want to use person first language when we're talking about obesity and avoid the term morbid obesity. So that's why we also use these classes. Moving on to type 2 in kids, we're seeing, unfortunately, a lot more type 2, and we sometimes even see this in kids before puberty, although it's much more common that kids will develop it during puberty or soon after puberty. These are data that show the increase in type 1 and type 2 diabetes. This is incidence per 100,000 on the y-axis, and these are years along the x-axis. These are pre-COVID data. And you can see we have a slight increase in type 1, which has continued, and a steeper increase in type 2, although in absolute terms, we see more cases of type 1 still every year than we do of type 2. Unfortunately, we had an even further increase in incidence and in acuity of type 2 during COVID. The percent of kids presenting in DKA with type 2 dramatically increased during COVID. You can see here the statistics in the bullet. And so again, unfortunately, 10 years ago, all of the pediatric endocrinologists were saying, oh, we don't have an epidemic of type 2 diabetes. And now we're getting close. Unfortunately, there really are high numbers of kids presenting in type 2. One of the reasons this happens during puberty is because kids are more insulin resistant during puberty. Higher insulin concentrations around tanner 3, 4, and 5, and 8-canthosis nigricans are quite common. We have, I think this slide is in part for a pediatric audience, but fasting insulin can be very, very high. So we get referrals for fasting insulin of 80, 90, 100 milliunits per ml in kids who are in the later stages of puberty, and they may have completely normal hemoglobin A1Cs. Another thing that's important when you're thinking about the possibility of type 2 in a kid is genetics. And you guys know this. If you have a parent who's diagnosed with type 2 before age 50, there's a 1 in 7 chance. And if both parents have type 2, there's a 50% chance that the individual will develop type 2, not always in childhood. But we're seeing kind of genetics and our environment come together along with insulin resistance that's normal in puberty and in part related to the growth hormone increases to give us a lot of new diagnoses, unfortunately. About 10% of the kids who present looking like they have type 2 have a positive antibody, and it's typically a positive GAD antibody, and there's some controversy about classifying these kids. Some endocrinologists think that they have type 1 because they have a positive antibody, and some endocrinologists think they have type 2, but may be at risk of advancing sooner. And you will have heard the term double diabetes or other terms like that indicate that maybe patients kind of have both. So we still don't have a great classification for that. But it does occur in about 10% of patients. And my personal opinion is that those kids have type 2, but I keep a very close eye on them because they are much more likely to need insulin sooner. and as you probably are aware by now, type 2 is much more aggressive than in adolescents than it is in adults. I'll show you some data from the Today study, which by now is over a decade old. But in that study, kids failed metformin monotherapy more than 50% of the time at about 2 years. And as in the presentation, a lot of kids with type 2 presented DKA. Until a couple of years ago, we almost exclusively managed diabetes in type 2 diabetes in kids with metformin and then insulin. And we would give insulin if they presented in DKA, which we still do, or if their hemoglobin A1C was over 8.5 or so at presentation, even if they didn't have DKA. We since have had liraglutide approved, and just this year, empagliflozin is approved. You adult endocrinologists are much more commonly saying that word than I am. Sorry, but we are now commonly using GLP-1 receptor agonists, and we have started using SGLT2 inhibitors as well. So what we commonly would do, and I think I have a treatment chart here, what we commonly would do is if kids are in DKA, we always start insulin. If kids are not in DKA, we're recommended to start metformin and consider adding a GLP-1 receptor agonist or SGLT2. My colleagues and I have seen lots of cases where kids will have A1Cs of even 9, 8.5, 9, and we'll start a GLP-1 receptor agonist and they'll come down, below 7. So that honestly is typically our first line. So DKA insulin, otherwise GLP-1 receptor agonist plus or minus metformin, and we're just getting familiar with SGLT2 inhibitors. And I do want to talk about DKA just for one slide in type 2 diabetes. Before COVID, we had about 10% of our pediatric type 2 cases presenting in DKA, and during COVID, we had about 20% of our type 2 cases presenting in DKA. We don't have great data for kind of the last year and the year before that, but it is pretty common for kids with type 2 to present in DKA, and about 13 to 30% of the time, they'll have a combination of DKA and HHS. Younger age predisposes to that. And when they have this combination, it's very tough. Acute kidney injury is quite common. Altered mental status is quite common. We treat DKA quite similarly as we do people with type 1, except we use more gentle hydration, and we often will use a slightly lower insulin drip than we use for type 1 diabetes. And you may need to give hypotonic saline if the osmolality is not dropping. That's especially if you have a combined case of DKA and HHS. In DKA and type 1 diabetes, we typically always use normal saline, whereas we do give lower hypotonic saline in DKA and HHS. And there's a lot of comorbidities. Unfortunately, we've had kids with thrombosis. Unfortunately, we had a child lose a limb here at our place. Soft tissue injuries, infections, and rhabdo can all occur. Okay. So these are data from the Today study. Although this is a little bit old now, it's worth showing, I think. Months since randomization along the x-axis here, and proportion free of glycemic failure, not having to go on to insulin. So this was a 1:1:1 randomization of about 500 kids, or 699 actually, to either metformin plus lifestyle, or metformin plus rosiglitazone. Unfortunately, the study was designed before the whole rosiglitazone thing, which obviously we don't use anymore. But you can see a pretty high glycemic failure rate here. Rosiglitazone and metformin actually was more effective statistically. The really surprising thing here, because of studies in adults like the DPP, are that metformin and lifestyle and metformin alone were not statistically different, which you can see here. And the other shocking thing was just that even in these kids who were followed really closely and given lifestyle modification, the rate of failure of metformin was really high, much more likely or much more common than we see in adults. And there's a question in the chat about type 2 versus ketosis-prone diabetes, and what are the differences. And I will say that we, and you can please feel free to come off mute either now or when we kind of end the case and have a discussion period. We typically don't use the phrase ketosis-prone diabetes. We typically, if kids really, really look like type 2 and they have a weak GAD and nothing else, we call them type 2. And if kids have positive antibodies, we call them type 1. And I know this kind of the term, there's other terms related to Brooklyn, but there has been this term ketosis prone diabetes. And we typically think that those kids are type 2, but that's at our site, and that's with other colleagues I talk to, but there may be varying opinions, and I'd be happy to hear them in the discussion period. I want to talk a little bit about the lifestyle intervention in today, which basically was not very successful. So again, that's quite different than what we've seen in adult studies. It was associated with superior short-term weight loss compared to metformin alone, but the weight loss was not associated with a greater duration of glycemic control in the primary analysis. There were benefits of lifestyle, especially when the kids did lose weight. So they were more likely to maintain their A1C rather than have it worsen, and also have their BP maintained and attenuated rise in LDL, et cetera. So it's not like it didn't work at all, but in the primary analysis, it was not nearly as effective as we expected it to be. And the session attendance was not great, but it wasn't awful. So it's not like the kids were randomized to lifestyle but didn't do anything. Most of the kids did come at least kind of half to 2/3 to 3/4 of the time. I want to shift to MASLD now, which is sort of a related topic because it's quite common, of course, in people with type 2 diabetes. You'll be familiar with this, I think, and so you know that the kind of first stage is just kind of simple steatosis, so triglyceride accumulates in the liver, as is shown here. These are all the triglyceride accumulations. In non-alcoholic steatohepatitis, or now it's called MASH, metabolic dysfunction-associated steatohepatitis, you have the triglyceride accumulation, but you also start to get inflammation, which is shown with these immune cells here in the dark blue, and some scarring. And then you proceed to fibrosis and cirrhosis. The scar tissue, or the fibrosis, is shown here in this blue staining, where the scar tissue replaces liver cells. So we do see this, unfortunately, in kids. And in the general population, there's about a 5 to 10% prevalence in kids. In kids with diabetes, it's much higher. And in kids with obesity, about 25% of them will have MASLD. There's a male predominance, just like there is in adults. It's highly heritable, just like it is in adults. And it is more prevalent, again, kind of genetics are genetics, right, regardless of your age. So it's more prevalent in Latinos and Asians, and lowest in African Americans, which is the same demographic patterns we see in adults. Usually it occurs around puberty, but we can see it in prepubertal kids, and it's been reported as young as like 3, 4, and 5 years old. Obesity is the largest risk factor. There have been studies of kids undergoing weight loss surgery, and about 60% of them have some form of MASLD. There is, however, also an entity of lean NAFLD. About 20% of NAFLD is lean NAFLD. And it's pretty aggressive and appears to be more severe in adults. So 20 to 25% of kids have NASH at diagnosis, and 10 to 20% seen and reported out of tertiary care centers have advanced fibrosis. So it's really a concern, just as it is in adults. There are recommendations for screening from, this is the North American Society of Pediatric Gastroenterologists and Hepatologists. The recommendation is to start screening with ALT at ages 9 to 10 for all children with obesity, or some combination of the things you see in the brackets there, basically other risk factors for MASLD. An important point is that ALT is normally slightly lower in kids than it is in adults, so we're recommended to use around 22 as a cutoff for girls and around 26 as a cutoff for boys, and those are lower than kind of the lab norms that you'll often see reported with ALT. And if there's persistently elevated ALT, more than 2 times the upper limit of normal over 3 months, we're supposed to send those kids for evaluation to hepatology. Routine ultrasound is not recommended as a screening test because of poor sensitivity and specificity, but I will say that a lot of kids are caught incidentally on ultrasounds. There are pediatric obesity guidelines from the AAP that came out in 2023, and they also recommend using ALT for screening. That said, ALT is not a great screening tool in those with simple steatosis. It's typically not elevated. So somebody could have, 60% hepatic fat fraction and not have an elevated ALT. You would catch that on ultrasound. But again, we're not doing ultrasounds, and part of the reason is because we don't have a great treatment for MASLD in kids. Lifestyle counseling is sort of the first line. There has been a study that reducing sugar-sweetened beverages helps. Fructose, has kind of a direct pathway to triglycerides when it's metabolized in the liver. So reducing high fructose corn syrup can make a difference. And this is one of the places where I'll talk about things off-label. a lot of us are starting with GLP-1 receptor agonists when we see kids with significant MASLD, because they have shown some effectiveness in adults, but as you guys know, they're not FDA approved. There have been a lot of studies of metformin. There are probably in the hundreds of papers about metformin and MASLD, and it really has very little effect, unfortunately, in meta-analyses and in systematic analyses, et cetera. We also have a new guideline out for obesity, and we're not doing a good job with pediatric obesity. That's kind of the bottom line. The evidence base supports that if there's a comprehensive family-centered lifestyle intervention that has at least 26 contact hours over 2 to 12 months, that can have an effect to modestly reduce body mass index. Unfortunately, almost no center in the United States is equipped to give that many contact hours. We hear all of our weight centers are backed up. Individual subspecialty referrals occur. We're just not doing a very good job. There are FDA-approved medications, and as you will have heard in the news, medication use is much more common in pediatrics than it was even 3 to 4 years ago. Orlistat has been approved for a long time. I don't know anyone who uses Orlistat for their patients. Liraglutide has been approved for a couple of years, and Wegovy was recently approved. I apologize for the brand name. Wegovy is semaglutide, so the weekly form of the GLP-1 receptor agonist. And depending on insurance, and again, this is an off-label comment, depending on insurance, people are generally using whatever GLP-1 receptor agonist they can get approved. Another strategy, again, off-label, is to use stimulants. So the brand name of this, which I'm saying because it's hard to pronounce, the generic is Vyvanse. And people are using phentermine and Topamax or topiramate. So there is off-label use in pediatrics and combination therapy. And weight loss surgery is absolutely possible in severe cases. Typically, it's not done until kids are at least almost done growing or finished growing. But a lot of centers are doing weight loss surgery for kids as well. And in fact, these are data from Teen Labs, 5-year outcomes, and this is comparing kids or adolescents to adults here. Teens are in the blue line and adults are in the orange line. And this top line is weight loss or percent weight change. And so you can see it's about equivalent between the teens and the adults. So weight loss surgery is effective. Now, these are mostly Roux-en-Y gastric bypass. There are sleeve data as well, but the Teen Labs Consortium, because most kids in the past were undergoing Roux-en-Y, that's what we have the longest outcome data on. This is a really important point here, and and I'm not going to make or not make an argument for surgery, but I do consider this to be factual. So there's actually higher rates of remission of type 2 diabetes when people get their weight loss surgery in adolescence as compared to this adult cohort here. So there are a lot of weight loss surgeons in pediatrics who argue that if you can get kids relatively early, again, you want to wait until they've stopped growing because probably the weight loss would affect the growth otherwise. But if you can get kids early before they have really severe comorbidities, we think that there's potentially a better chance of attenuating those comorbidities. Finally, I wanted to make a comment about transitions in diabetes, and this is true for both type 1 and type 2. And basically, anytime I have an audience of adult endocrinologists, I like to talk about this because we still have a lot of work to do here as a community together. There was a recent pragmatic clinical trial that found that almost half of 17 to 18-year-olds in the usual care arm didn't attend an outpatient appointment with their with an adult diabetologist 1 year after they were transferred from a pediatric diabetologist. And there's a lot of issues here. There's some really nice work from Kate Garvey, that's the top citation here, with qualitative kind of conversations with people. And the patients, I think it is true that in pediatric endocrinology, we quote baby our patients much more than happens in the adult world. And the waiting rooms look a lot different, right? And so, this is a patient perspective. It's a huge shock when you come in and see these elderly folks with walkers and canes. And it's overwhelming to go from one end of the spectrum to the opposite. And providers feel that the people we send them, the young adults we send them, are generally ill prepared to face responsibilities as an adult diabetes patient, and they're coddled too long by their parents and their pediatric practices. And there is some truth to that. I don't know if coddled is the right word, but there's this whole concept of kind of emerging adulthood, and becoming an adult is a much longer process than we used to consider it, and can take up to age 25 or 30. So we're trying to do our best with transitions. It's a really high risk period. The A1C is typically quite a lot higher than is recommended. There's a high percentage of psychiatric comorbidities, especially increased risk of depression and eating disorder. And up to a third of kids are lost. Up to a third of kids with type 1 are quote, lost during the period of transition from their pediatric endocrinologist to their adult endocrinologist. And this does result in a higher rate of diabetes-related hospitalization. So in terms of best practices, there's not anything that's perfectly defined yet. Although the more that we can kind of make sure that our patients get their adult appointments, and the more that adult endocrinologists can reach out if patients are missing appointments. And I do think actually, and I don't think that's on this slide, but incorporating parents. A lot of kids really are used to still relying on their parents for things like appointments and refills. And whatever our judgment about that, it is factual. So we very often have 18, 19, 20-year-olds still coming to their appointments with their parents. That's a very weird thing, I bet, for an adult endocrinologist. But that is something to kind of keep in mind. We're trying to provide transfer summaries for all our patients, and screening for comorbid psychiatric conditions. I'm just going to take a second and read this comment. Yes, this is a great question. How do you tactfully address the concept of health at every size versus obesity, especially if there are not any metabolic diagnoses that suggest an intervention is needed, though the risk is elevated for metabolic dysfunction at a later age? Thank you very much for that question. That's a fantastic question. It's a controversial question. I'll tell you my own opinion on it is that I very much believe in affirming kids, and I think and I saw this during my own training, which wasn't that long ago. It was, 15 to 20 years ago, a lot of shaming. And I think it still happens, unfortunately, in a lot of pediatricians' offices, and in a lot of subspecialists' offices. So shaming around obesity just makes things worse at every single level. I see a lot of parents shame their kids around their obesity. So I really do try to affirm that I just want kids to be healthy. One of the reasons one of the kind of themes of that is that exercise is for mental health, and exercise is for feeling good, and exercise is actually not for weight loss. Healthy eating is for feeling good and not necessarily for weight loss. And I do think it's good to frankly have those discussions with patients. I try to let the patient guide me on what they want. A lot of people are depressed, are feeling, their social situations are difficult. And I do often offer medications. I never push weight loss medications, but I do often offer weight loss medications for kids with class 2 or 3 obesity, who are in their adolescent years. But thank you very much for the point. And if anybody has other comments or questions, I think it's a really important concept. I think the person first language there is important. I try as my very first thing to find out how people feel about their weight. I don't tend to kind of push weight discussions in patients who are there for puberty or thyroid or other things, unless they bring it up. I try to let patients guide the discussion. And thank you very much for the question. And I think we're at the end of this section. And so I'd be happy for people to put other questions or comments in the chat, or also if you'd like to come off mute and make any comments or ask any questions. It's a really difficult conversation. Yes. Yeah, I think And a lot of kids cry during the discussion, and I used to consider that a failure, but now I think, as long as, I try to just be as kind and loving as possible and as accepting as possible. And I think acknowledging that it's a really hard thing to carry extra weight in our society. And I wish that wasn't true, but it is true. So, yeah. Um, Okay, I will move on to case 3, but feel free to put any additional comments in the chat. And this is our case of growth hormone, so we can contrast it a little bit with the constitutional delay we had earlier. This is a 31-month-old. He's over an adult endocrine by now. This is a case I had a long time ago, but so I'll show you his growth chart. He started to cross height percentiles at 1 month of age and fell below the 5th percentile at 9 months. His kind of review of medical history and meds, et cetera, was pretty unremarkable. He'd met all his developmental milestones, feeling well. Parents, sorry, I didn't put centimeters in for those of you who use centimeters primarily, but kind of normal height parents, no short stature or delayed puberty in the family. His proportions were normal. His arm span to height was pretty normal. His upper to lower segment was pretty normal for his age. And he had normal genitalia and no dysmorphisms. So this is his growth chart. And again, this is kind of an old school case. Okay, so this is when we used to have the growth chart in the chart and write with a pen on it. This is a birth to 36-month growth chart as opposed to the ones that we typically use for older kids. And you can see that this kiddo really started falling off pretty early, and he stayed falling off. The weight is down here since you're not used to looking at these, and this is the length. So his weight is relatively preserved compared to his height. And he started falling off pretty early. Now, this does not always happen with growth hormone deficiency, that kids will fall off this early, but this kind of pattern of falling further and further away from the curve is pretty common. So I did a laboratory evaluation, lots of normal stuff, normal thyroid. His IGF-1 was less than detectable, and his IGF-BP3 was also on the lower side. We did a cortisol, which was fine. Our next step, and I'm going to talk some about this, was a growth hormone stimulation test. For him, we used clonidine and L-DOPA, and he had a peak growth hormone of 6.9. Nanograms per ml or micrograms per liter, which typically I don't consider too bad, but taken with the rest of the data, including the low IGF-1 and the pretty horrible growth chart, we diagnosed him with growth hormone deficiency. The next step then is to get a pituitary MRI, and that was normal. And we started him on growth hormone. Our dosing, we kind of calculate per week, which I think is a vestige of when they used to give pituitary growth hormone 3 times a week. But this is a pretty standard starting dose. And you can see what happened here. So now we've shifted to the 2 to 20-year-old growth curve. Again, this is weight down here and this is height here. And you can see that he was way below the curve, and he kind of caught up on growth hormone and did pretty well. He ended up being about, I don't have it on here, but he ended up being about 167 or 8 centimeters or 5 feet 6 inches tall. What I want to talk about is the diagnosis of growth hormone deficiency and the management of growth hormone deficiency in transition. I'm going to spend a little bit of time on diagnosis, and I apologize for belaboring it, but I think it's important that adult endocrinologists know kind of what a mess we're in pediatrics in terms of how we're diagnosing growth hormone deficiency. Because you're going to inherit a lot of kids who had a diagnosis of growth hormone deficiency, and it's going to be unclear if they should continue treatment or not. An aside at first is just all the different things we're approved to give growth hormone for in pediatrics. Turner syndrome, which has some metabolic benefits, but is basically for height. Noonan syndrome, Prader-Willi syndrome, and I understand that some adult endocrinologists are now continuing growth hormone in adults with Prader-Willi for its metabolic benefits, chronic renal failure, small for gestational age without catch-up, SHOX gene mutation, or idiopathic short stature. And so in terms of diagnosing pediatric growth hormone deficiency, provocative testing is required by insurance in almost all states for a definitive diagnosis. And that said, our provocative testing is a mess. So we have a bunch of different agents. It's not standardized as it is in adult practice. So we have clonidine, arginine, L-DOPA, glucagon, insulin. We used to use growth hormone releasing hormone, but we all know it's not available. We don't use mesamorelin yet. And most of us don't use insulin anymore just because of the risk of hypoglycemia and the need for close observation. So people use a variety of these tests, and they either use them in combination. So for example, you'll give both clonidine as a pill and start the arginine infusion at time 0, or they use them serially. You'll give clonidine and then give arginine 2 hours later, or you'll give clonidine and they'll come back, a week later and get arginine. So all kinds of variations in that regard. Regardless of those variations, we all have been in the practice of using a peak of 10 in the United States to define growth hormone deficiency. And as you know, the growth hormone assay is not fantastic. And so just a quick note here that there was this nice study that's cited down at the bottom of the slide that showed that the diagnosis of growth hormone deficiency is dependent on the assay in 27% of a cohort of kids. We know that our growth hormone stimulation testing has pretty poor short-term reproducibility. This is a pretty old study of 33 pubertal kids who either had a clonidine test, an arginine test, or an insulin test. And these tests were alone, not simultaneous with each other. So you can see that all these 33 kids failed their first 2 tests, and then they came back for a third test anywhere from 1 to 6 months later, and 28 of them passed. We also, again, these are really old data from the NIH. These kids underwent either an exercise tolerance test or arginine or insulin. And these were actually a cohort, again, you probably wouldn't get approval for this study now, but 84 healthy girls and boys of normal height and weight. And in that study, you can see the line here for what we would consider failing. It's a logarithmic axis. And this is by Tanner stage. So Tanner 1, Tanner 2, Tanner 3, et cetera. So again, these are perfectly normal kids who are healthy, and 31% of them failed the growth hormone stimulation test. We also know that when we retest people in adulthood, if they've been diagnosed with isolated growth hormone deficiency, the I is for idiopathic in this case, idiopathic growth hormone deficiency, we know that about 45% of them pass tests in adulthood. This is a useful graph because it shows that if you have one additional pituitary hormone deficiency, you're much less likely to quote pass or recover. And if you have 2 or more, basically the chances are incredibly low that you would pass your subsequent growth hormone stimulation test. And this is a recent meta-analysis. This is each study along the x-axis here, and this is the quote reversal rate. So here, for example, a reversal rate of 25% would mean that 25% of the kids who had idiopathic growth hormone deficiency diagnosed in childhood now are testing completely fine. And the different labels here are basically what cutoff they use. So the green X's use a more stringent cutoff and therefore have higher reversal rates, which is not surprising. And the diamonds are the least stringent cutoffs here. But basically the reversal rates are very high. We know that those who have MRI abnormalities are more likely to persist with growth hormone deficiency in adulthood, but we also know that some people with pituitary abnormalities will test completely normal. So the guidelines recommend that if, say, someone has a small pituitary or ectopic posterior pituitary and isolated growth hormone deficiency, you still do retest them in adulthood. So what's going on here? Are we misdiagnosing all these kids, or is there some kind of reversal like there sometimes is in IHH where all of a sudden the pituitary picks back up and does what it's supposed to? And some people do argue that the growth hormone axis matures during puberty under the influence potentially of sex steroids. And again, there is a precedent for that in people who evolve out of their IHH. And certainly you don't need as much growth hormone in adulthood, and you secrete less growth hormone in adulthood. However, I think my opinion as a pediatric endocrinologist is that we're vastly overdiagnosing these kids with growth hormone deficiency. There's a lot of social pressure on parents, and then that pressure translates to us to diagnose kids with growth hormone deficiency so that we can give them growth hormone. When you take kind of what we know to be the incidence of growth hormone deficiency among kids with short stature, about kind of 1 to 2% of them should have growth hormone deficiency. And our data show we diagnose about 30% of kids with short stature with growth hormone deficiency with the provocative testing. So I think for sure it's overdiagnosed, and there may be some component of reversal as well. What does this mean for the transition period? And then what will it mean for you later, which we'll get to in a couple of slides. So when kids are almost done growing, so their growth velocity is less than 2 to 2.5 centimeters a year, and or their bone age shows epiphyseal closure, which is about 15.5 to 16 in girls or 17 to 18 in boys. We are supposed to discontinue childhood doses of growth hormone. And you probably know, so if I had a 14-year-old boy on growth hormone, he would probably, it's titrated to IGF-1 levels, but he probably would be on 2.5, 2.6, milligrams per day. So really, really high doses compared to what's given in adulthood. If somebody has multiple pituitary hormone deficiencies or structural pituitary lesions beyond just hypoplastic or ectopic posterior pituitary, or a proven genetic cause of growth hormone deficiency, you can do one of two things. You can either just reduce the dose and continue therapy without interruption, or, and this is kind of patient preference too, you can stop the growth hormone for at least a month and then repeat an IGF-1. And then if the IGF-1 Z-score is low, then you go ahead and restart the growth hormone if the patient is willing. In folks who just have isolated growth hormone deficiency, or they have one other pituitary hormone deficit, we're recommended to discontinue, retest the IGF-1 after 1 or more months. If the IGF-1 standard deviation score is above 0, we observe off therapy. And if it's less than 0, we're recommended to proceed with a growth hormone stimulation test. Now, typically, we have a lot more information than that. We know how the kid presented to us. We know what their growth hormone response to provocation was. So I do tend to kind of modify this a little bit based on what my pretest probability is that the kid actually has growth hormone deficiency. But the bottom line is that when kids are done growing, we need to for sure reduce the dose in those who we think are very likely to have growth hormone deficiency, and we need to take kids off growth hormone and do a reassessment in those who we have a low suspicion of growth hormone deficiency for. In terms of timing, it is important that we do this in a timely manner for those who may have persistent growth hormone deficiency. And the reason for that, as you know, is that adolescence is a critical period for accruing bone mass and in males, skeletal muscle mass. And so there are studies that show that if a kid is taken off growth hormone and they have persistent growth hormone deficiency, but they don't get back on their growth hormone for 2 or 3 years, they're much more likely to have kind of lower bone mineral density and potentially adverse effects on skeletal muscle mass as well. So what are we supposed to do for dosing? An older guideline recommended starting at about 0.2 to 0.5 milligrams per day, and a newer guideline that's referenced down there from 2019 from Kevin Yuen recommended having the pediatric dose. And basically, I don't think there's any right versus wrong answer here. There's kind of two principles. The lower you can go in the growth hormone dose, the lower your risk of side effects, of course, and insulin resistance. But the other principle is, if you look at IGF-1 levels over time, it's not like you finish growing and then drop off a cliff. And so it makes sense to do this more gradually, probably after completion of growth. And so if you have a young adult, they're likely to tolerate higher doses of growth hormone than older adults, because that's what they would be making themselves, in fact. And so what I typically do, I do often actually start with 0.5 or 0.6, and then I guide based on serum IGF-1 levels, but you could certainly have the dose instead. And I have done that in a couple of people who are really hesitant to go down so far. But those are the basic principles of transition for growth hormone. Any questions or comments? Feel free to put anything in the chat or come off mute. Okay. The next case is also a pituitary case. This is a young man who presented after being hit in the head, I think, during a baseball game, and he realized he couldn't see things on the right side very well. And he got an MRI, and it showed a tumor in his left suprasellar cistern involving the left optic pathway. So he had partial resection and chemotherapy and proton beam radiotherapy. And I met him later. He was diagnosed with DI soon after presentation. And then he presented to the emergency room because of increasing weight and fatigue. And then he was diagnosed with pan-anterior hypopituitarism and started on replacement. And you can see his growth curve here. So again, height's at the top, and thankfully, he had pretty much finished growing when he was diagnosed. But you also see this precipitous weight gain, which is common with hypothalamic obesity. and we'll get to this. He had a weight loss surgery, which is what that reduced weight over there is. What I want to talk about with this case are the endocrine morbidities after CNS tumor and radiation, the current evidence on post-malignancy growth hormone replacement, and the general guidelines for endocrine surveillance for cancer survivors. So a lot of the data I'm going to show you is from this St. Jude lifetime cohort. This is from 748 kids treated with cranial radiotherapy, and they had a mean follow-up of 27 years. And they did, for the diagnosis of growth hormone deficiency, they did use IGF-1 Z-scores, so not perfect, but they had to be less than -2. That should say negative right there, sorry. And they used a morning cortisol less than 5 for ACTH deficiency. Along the x-axis here, you have the percent of people who are deficient in that hormone, and along the y-axis, you have the percent with one other deficit or more, and the size of the bubbles is proportionate to the percentage of kids who have the deficiency. So you can see that a lot of kids had growth hormone deficiency, gonadotropin deficiency was slightly less common, TSH slightly less common, and ACTH deficiency slightly less common. So the message here is we see growth hormone deficiency very, very commonly when people have radiotherapy. It can take several years to develop, depending on what was going on in the pituitary in the first place. And we're less commonly seeing other pituitary hormone deficiencies. The amount of pituitary hormone deficiencies typically depends on the amount of radiation. So this is from one of the guidance documents. If you have at least 10 grays to the pituitary, then you're at risk for growth hormone deficiency. If you have at least 18 grays to the pituitary, then you're also at risk for central precocious puberty. And if you have at least 30 grays to the pituitary, then you're at risk for kind of panhypopituitarism or any given pituitary hormone deficiency. And anecdotally, when we see kids who've had more than 50 grays, they're very commonly panhypopit, or at least have a lot of pituitary hormone deficiencies. And as the graph shows, the ACTH deficiency is typically the least common that we see, and is often the last to present. What's on the bottom here, of course, is tumor or surgery near the hypothalamus and pituitary, which also puts one at risk for all of these things. So the extent of tumor involvement in the sella also matters a lot, of course. Oh, sorry. Oh, that was bad. Excuse me. So in terms of recommended monitoring, I'm going to bring the table up, but I'll start talking about it. The bottom line is that, unfortunately, these kids, or not unfortunately, I guess, these kids need to be monitored throughout their lives. Especially with pituitary radiation, the effects can be quite late. Here we go. Yes. So we need lifetime periodic assessment. And if you're going to do growth hormone stimulation, you need an agent that doesn't bypass the hypothalamus. So for example, if somebody had hypothalamic deficit and you use GHRH stimulation, but their pituitary was working okay, then you might get a false normal result. We need pituitary evaluation, or sorry, pubertal evaluations, growth evaluations, thyroid screening, and adrenal screening. And again, if you're kind of at least 30 gray is when you really have a high suspicion for these things. And then this is just a slide about the risks of growth hormone replacement after a CNS tumor. This is a very nice sample size of about 338 kids who had growth hormone treatment compared to a lot of kids who didn't have growth hormone treatment. And there was a development of secondary CNS neoplasms in those who were GH treated versus non-GH treated. The risk ratio, however, for any CNS neoplasm was null. What we did see is that there is potentially an increased risk of meningioma and potentially an increased risk of glioma, and both of those increase in association with radiotherapy as well. Yeah, so I don't have another slide about this, but I can say that our current practice, especially if kids are still growing, is to give growth hormone replacement when they're at least 1 year in remission, so to speak. And we give the growth hormone replacement very carefully. I try to keep the IGF-1 Z-score around 0, and frankly, as low as I can to optimize normal growth. But we are giving these kids growth hormone replacement, and we typically, although there's a small increase in the risk of secondary neoplasm, we typically think this is a relatively safe thing to do with close monitoring. Back to our patient who I actually still follow. really interesting that his hypothalamic obesity has really been the hardest problem to manage. He is on phentermine and Contrave and Ozempic. Again, I apologize for the brand name. So GLP-1 receptor agonist, phentermine and topiramate, and bupropion and naltrexone and metformin. He also receives Adderall for ADHD. He receives pan-pituitary replacement. And he actually, so he had a weight loss surgery with a vagotomy back about 8 years ago. I think he had a nice weight loss with that, but unfortunately started to gain it back. And he recently has started a randomized controlled trial of setmelanotide versus placebo. It's hard to blind that study because setmelanotide causes a pretty significant amount of pigmentation, which he has, and he's lost 30 pounds. So that's really interesting and potentially very promising. Any questions or comments on this case? All right, and we are almost done. The last thing that I want to bring up as a topic is transgender management. And I don't have a bunch of slides here. If people have questions or want to have a discussion, I'm delighted to do that. And if people want to go have dinner, I'm delighted for you all to eat dinner. The presentation is a 13-and-a-half-year-old transgender male who presented with significant gender dysphoria leading to self-harm. He had menarche at age 12, and his parents were supportive and wanted to help him with his dysphoria, but were not, and I apologize, this is kind of old language, they didn't yet, they weren't yet ready for him to have gender affirming hormones, which we used to call cross-sex hormones. So I want to talk a little bit about GnRH agonists in transgender care. We currently have monthly, Q3 month and Q6 month injectable GnRH agonists, as well as hystrelin implant. And we do use these pretty commonly in kids with gender dysphoria with parental permission. You obviously can't use or shouldn't use them prepubertally. We do use them as soon as someone either has 4cc testes or breast budding. And often we confirm with a morning LH, but that's not completely necessary if the exam is clearly pubertal. Ideally, these can be used before kind of a bunch of exposure to either testosterone or estrogen, at which time they can cause some withdrawal symptoms if you use them. We also can start them mid-pubertally, but I do worry about the effects on growth spurt when we do that. And again, when we use them at or near the end of puberty, this young man had already had menarche, for example, and was eventually started on a GnRH agonist. It does cause kind of menopause-like symptoms. So kids can have hot flashes, unfortunately, or some effects on energy. There is a concern about hormonal withdrawal, which I just mentioned, also sterile abscess, which can happen with the injectable forms. And we do worry about bone density accrual. There are increasing studies about this. In our precocious puberty kids who we treat, there can be slower bone density accrual while you're on GnRH agonists, but it does catch up. And so far, the data support that in trans individuals as well. Interestingly, transgender individuals often come in with a lower bone density, and we have not figured out why that's the case yet. But this is certainly something that we talk about. It is a real risk and something that we need a lot more study on. And then gender affirming hormone therapy. The Endocrine Society guideline says to wait until age 16. And I actually don't remember what the new WPATH guideline says. That said, a lot of endocrinologists are initiating around age 14 if the parents are in agreement and the child is in agreement and the mental health provider is in agreement. The reasons for that are twofold. The main one, in my opinion, is bone density. And the second one is that it mimics normal puberty better, I should say the timing of kind of the average timing of puberty is better mimicked if you start around age 14. We start very, very slowly if we do this. And we keep the GnRH agonist on typically, and then, or if there's menstrual suppression with norethindrone acetate, for example, we keep that on and go up every 6 months or so. And again, this is in conjunction with mental health specialists. I think you guys got these slides, and I put them here mainly for reference. With testosterone, I am typically using sub-Q testosterone and starting with about an eighth of an adult dose, and then going up slowly as shown there. And then you can start using the pump or the gel once you get to kind of a slightly higher dose. And for estradiol, ideally, people are using either the patch or the oral 17-beta estradiol or estrase, which is much more kind of physiologic than kind of ethinyl estradiol or something that that you would get like in a birth control pill. Transdermal is probably better because it avoids the first pass hepatic metabolism. I think that's probably a concept that's familiar to all of you guys. And you can cut the matrix patches as long as it's a matrix patch and not a reservoir patch. You can cut them if necessary, although a lot of the patches now have really nice low dosing. So again, I didn't have a ton, but I did want to mention transgender care in case it's on anybody's mind and people had questions about it. Would be happy to take questions about it. Or comments. And kind of for the whole talk, the take-home points are that type 2 diabetes is a lot more aggressive than it is in adults, and it may present with DKA and or HHS. The diagnosis of growth hormone deficiency in our pediatric endocrine hands, unfortunately, is pretty uncertain, and transitioning requires timely retesting. We do need lifetime surveillance of pituitary function in childhood cancer survivors who've had cranial radiation. Transition age patients are often not ready, so please coddle them a little bit. And give them extra support and outreach. And thanks everyone very much for coming and for attending the course in general, and happy to take any other questions. And I'll just stay on for a few minutes, but you guys should feel free to go enjoy your lunch. Thank you very much. I appreciate it.